Good afternoon. My name is Debbie Taylor.
And I'm Bodie Jenkins.
And we're here to do an educational video today with you on flipped classroom educational model on chest tube drainage systems. So prior to the class meeting, the pre-licensure nursing students were asked to review the appropriate literature within their course materials, to view an online video on the anatomy and physiology of the respiratory system and breathing, and completed 10 NCLEX type question pretest. The goals of our video today, goal 1 is pre-licensure nursing students will be able to identify their role in setting up a closed drainage tube system. Goal number 2, the pre-licensure nursing student will be able to identify and discuss troubleshooting and complications with the closed chest tube drainage system. Goal 3, the pre-licensure nursing student will be able to discuss their duties in assisting the provider with discontinuing or pulling a chest tube. And goal number 4, the pre-licensure nursing student will pass the 10 NCLEX type question post-test with a 90% grade or higher. Okay, the video website that we ask the students to review is this website. And this website, we're not trying to sell the product that's on there. It's just the website that we found, and it's got some good anatomy and physiology on the respiratory system. So we asked the students to review the video prior to coming to class.
And in particular, that video talks about in-depth, well, not in-depth, but it's a short 3-minute video of just basic anatomy of the pleural space itself and how the pressure in the pleural cavity is maintained and why there is a need for chest tubes.
Right, exactly. It talks about the anatomy of the lungs, that there's the ribs, sternum, and thoracic vertebrae all within the chest cavity. Talks about the pleural fluid and the pleural areas and the pleural fluid that enables these areas to move against each other when people breathe, and that's done under negative pressure. But if something happens and that negative pressure is removed, then you can have air, fluid, blood fill up within the lungs and the pleural cavity, and that can lead to tension pneumothorax. And if that pneumothorax isn't identified soon enough, it can lead to a life-threatening situation such as a mediastinal shift. So it's really important that we do great assessments on our patients and know when a chest tube might have to be inserted in the drainage tube system might have to be used. Okay, and the main reason why we do use the chest drainage system is to remove accumulated air, fluid, blood that's within the lungs so that it can go back to the normal
homeostasis.
Homeostasis, right.
Right.
Okay.
And equalize the pressures.
Equalize the pressures and get back to normal.
Correct. So that was a good 3-minute video just as a review for the students before we get into the meat of chest tube. So just a good review.
Yes, a good review.
So they can understand
exactly on why we're using the chest tube.
And like Deb said, the main reasons we insert a chest tube: hemothorax, pneumothorax, pleural effusions,
yes,
trauma.
Exactly.
Trauma can cause the pleural cavity to be interrupted, air to be allowed, and when air is allowed into the pleural space, shrink up goes your lung.
And the patient starts having difficulty breathing.
Right. Okay, so moving on to the actual chest tube setup and insertion. So goal number 1 was the student will be able to identify their role in assisting the provider or the physician with inserting a chest tube.
Mm-hmm.
So there's many different closed drainage system devices on the market. This is just one that we have handy here that we'll go over. They all, the background of them or how they work is all very similar. Depending on the manufacturer, of course, there's going to be some slight variances, so it always pays to read the manufacturer's recommendations or instructions on how to set it up, because they are slightly different. Now this will come in a sterile pack.
Right.
So this entire unit comes sterile. So if you're in the operating room or a completely sterile environment, of course you would don your sterile gloves and open the sterile pack, and then you have a sterile field. Most of the time, however, when we insert chest tubes, it's in a non-sterile environment unless you're in the operating room.
Right.
So once you take it out of the pack, you don't have to maintain sterility on this system itself. There is one area that you must maintain sterility, and that's the end of the tube that goes to the collection drainage system. This is the part that stays sterile. This will hook to the actual chest tube that the provider will insert into the pleural cavity. And we'll get there in a second on how to do that. But let's go over just the parts and how to set up the closed drainage system first. So in this particular model, when you get it out of the pack, on the back side, now this one's been removed, but right here is a syringe, and it's got the predetermined amount of water in it that is required for your water seal. You take the pre-filled syringe, right here on the blue suction port, put your syringe on, and you fill. Now this water will go down here into the water, 2 centimeters into the water seal chamber. Okay? And it'll turn blue, and it'll be up to the 2 centimeters. So that's the first thing you have to do. Okay? Just to get to know your parts here, this is the centimeter of water pressure that the surgeon will tell you what to set it on. Normally it's minus 20 centimeters of water, but there is a dial on the side. So if the doctor says, I wanted it negative 30, then you just move the dial. And you can see there, and the dial just goes up, and you can set it to whatever pressure you want. Okay? This is the collection chamber for any fluid that drains from the pleural cavity, and you see it's graduated. So if the patient has a chest tube for days or weeks, you may be doing output measurements, Q4 or Q shift, depending on what the doctor's order is. And there's room to mark with a Sharpie the date and time, and it's just a running log. Okay? Let's see. This part here, this orange, this spot here that says E, there's an orange bellows in there. If you're not just going to have it on water seal and the doctor orders suction, this is where your suction tubing hooks to. You would hook it to wall suction or portable suction. Turn your suction up to at least 80. And in this particular model, when the suction is working, this orange piece right here will come out and you'll see it. So that's how you know that your suction is actually working on this particular model. It has a floor stand that you can set it on the floor right here. However, it does have the hooks. And it's preferable when you have a closed drainage system chest tube to hang it on the bed rail below the patient, because it is gravity and suction fed. If it's on water seal, it's 100% gravity fed. So of course you don't want it up higher than the patient's chest. So that's the main parts of a closed drainage system. Is there anything to add on that, Deb?
And I think a lot of times most of your facilities recommend that you hang the drainage system on the bed, because if it's sitting on the floor, even though it does have a floor mount that will help it sit straight on the floor, if you're moving around the patient's bed a lot, it could get tipped over. So usually follow what your facility's guidelines recommend that you do.
The only other part I haven't talked about is the actual tubing that goes to the collection device. Okay? So when you're inserting or assisting a provider in inserting a chest tube, for one of the reasons that we discussed at the beginning, first thing you want to do is identify the patient with at least 2 identifiers.
Right.
Of course, if it's in a trauma situation, in an ER, that's not quite as pertinent. However, we always identify your patient and procedure within a quick timeout.
Yes.
And if you haven't learned about timeouts yet, you soon will.
Yeah.
Because any procedure you do, it's a requirement that you do a timeout. So always identify the patient with 2 identifiers. Verify the signed consent. The patient has to consent to this procedure, again, unless it's trauma and the patient's unconscious. It's in an ER setting. Other than that, the patient must consent to this procedure because it is a quite invasive procedure. Wash your hands and don appropriate PPE. That goes for anything. Anytime we're touching a patient, of course, appropriate PPE is always required.
And PPE is your personal protective equipment, which will consist of gown, gloves, face mask, eye shield, anything that's appropriate for the procedure that you're doing.
If it's a suspected or if it's a known hemothorax, the gown and the face shield are imperative, because if you have a liter of blood in that pleural space, when you pop in through the pleura, guess what? I've seen them in the emergency room, and it comes out and makes a mess because that blood,
you don't want that in your eyes.
As soon as you open that chest cavity, the blood just comes pouring out. So the PPE is quite important. So don't forget that. So then, assisting the provider, once you put your water in and you have your closed drainage device ready to go, really all you're doing is waiting for the provider to insert the chest tube. This is what a chest tube looks like. That's going to go in the patient. This is the part that goes into the patient. And if you notice, there's holes in different areas completely around the circumference of the tubing. And that's to collect the most drainage as possible. If we just had one tubing here, it could get occluded, or it could pull the lung tissue up against it. So that's why there's many holes. And when the provider inserts this, he will make sure that this very last hole, the most proximal hole here, will be covered up and actually into the patient. If not, you'll have a big air leak, and we'll discuss air leaks when we get into troubleshooting and complications. This is the end that will be sticking out of the patient. So when the provider inserts it and he's ready to go, this tube will be in the patient. All you're going to do is remove this top and hand it to the provider, and he'll hook it up. That's all you have to do. It's very simple to assist in this procedure. If for some reason you drop this on the floor and it becomes contaminated, you don't wipe it off. You just go get another one. Go get a new system. This tube goes directly into the chest cavity. It has to be maintained sterile. So that's all there is to assisting a provider in inserting a chest tube. When we hook it up, so let's just pretend that this tube is in a patient. The doctor will slide this in here, and hopefully he will put it nice and secure. Now when we take this, a lot of times the doc will say, all right, it's all yours now. Of course, he will dress this area up against it. He'll suture it in, and he'll dress this area with an occlusive dressing, and he'll handle this end at the dressing side. Here where we connect, it's very important that this connection doesn't come undone. Okay, if you could hold that for me. So silk tape works great, and what you'll see a lot of people do is they'll just do the old wrap around, wrap around, wrap around, wrap around, wrap around. This is not the preferred method, because if you have a lot of drainage and there's a small leak here, when this tubing gets wet, this round and round type tubing, it's easy to slide it out. So you slid it out. The other thing that doing this, taping this way does, it totally obstructs your vision of what we call the football here. In this tubing, this is the smallest diameter portion. So if you have a lot of fibrinous material coming out, if there's going to be a clot develop and occlude your drainage, it's probably going to be in here. So you want to be able to see this part. So the preferred method of taping a chest tube and securing it, if you could hold that for me, Deb, is to do one long strip, long ways. Hold it up a little higher. There we go. So you want to do a long strip, kind of wrap it around your tubing like this. That way, this side you still can completely see. You're not occluded whatsoever. Then, around each side, then you just do your wrap like this. Around each side. And this is the best way to secure your closed drainage system tubing to the actual chest tube that's in the patient.
And it's called the H wrap, okay, because it basically looks like an H.
And if you have leakage here, you'll be able to see it. And because of the way one solid piece of tape going across,
it's not going to come apart.
You can't pull that apart. So this is the preferred way to tape it. So please, please, please pay attention to the way you tape chest tubes. The other way, I've had real-world experience where it's come out, the patient with a hemothorax, it's a mess. Again, you just introduce atmospheric pressure into the patient, and if whatever progress you've gained on expanding that lung, you could have just lost it. Could have send the patient into respiratory distress or death. Yeah, exactly. All right, so I think we covered everything as far as setting up.
So we're going to look at trouble.
No?
Not that I can
cover everything setting up.
We thought we'd go over troubleshooting next with the drainage system. Sometimes when you're doing your assessment and you're looking at the drainage system, you might notice that it doesn't look like there's any drainage, or the drainage is extremely slow. One of the things you might want to do is check the drainage system to make sure that it's upright, that it hasn't fallen off the bed, or that if it was sitting on the floor, that it didn't fall over on the floor. If the drainage system is attached to the bed and everything looks fine with the drainage system and none of the tubes have come disconnected, then you may want to elevate the patient. Elevating the patient into a semi-Fowler's position will also help enable drainage from the chest tube side. Another thing you might want to do if that still doesn't work, you might want to turn the patient, have the patient take deep breaths, cough, and see if that might help. There might be some buildup of some fluids and stuff right there at the chest tube site, and doing this will just kind of dislodge that and help the drainage. If it continues to have problems, sometimes you may have to clamp the chest tube with the system, and if that happens, you want to wait. If you realize that something's wrong with this chest tube system, it's not working correctly, then you need to probably replace it. The best thing to do is not clamp and go get your piece of equipment. What you need to do is go get the next, another chest tube system, drainage system, and then have it opened. Remember, it's going to be in a sterile container. Have it open, get everything ready. Then you want to clamp the tube, disconnect the tubing, and then reconnect everything. That way the patient's only been, it's only been clamped off for a short period of time.
And why is it important to only clamp it for a short period of time?
Well, because what's happening, what are you using that chest tube for? It's to let the air come out and fluids and blood drain from that system. And if you don't do that, then that's going to build up inside the
potentially cause a
pneumothorax,
right. Potentially. So unless there's a problem or it's a doctor's order,
right,
don't clamp the chest tube.
No,
is the bottom line.
That's your last resource. And then if you're still having problems, you want to contact the physician. Another problems with troubleshooting, you might see that there's an air leak down here where the water goes, where it's up to 2 centimeters, right here to the 2 centimeter line. You're going to see a slight bubble occasionally. That's just going to show you that the system's working correctly. But if you start seeing a progressive bubbling that's continuous and it looks pretty hard, then there's something wrong, and it may mean that there's an air leak. So you need to check all of your tubing and make sure that you're not having any problems. That 1 or 2 bubbles is okay, but a consistent vibrating bubble is not okay. Okay. And then another, and I think that was it for the air leaks. You also want to look at the catheter, make sure that it's not kinked and that it hasn't somehow, that the tubing's become elevated higher than the chest tube system. And then if you still can't find anything, you might want to notify the physician that there's a problem with the system. Okay?
So what if you have it on the floor or it's on here and the patient gets out of bed and tips over?
You can lift the system back up. The way the chambers are done, you turn it basically on its side
to the right,
and everything is going to.
Yeah, this manufacturer recommends
that you turn it to the right. So do follow your manufacturer's
Mm-hmm.
instructions. So turn it to the right, and most of your fluids should go back to the chambers that they're supposed to be in. Again, if that doesn't happen, if you feel like the system isn't working correctly, then you need to replace it. Okay. All right.
So what did we talk about for complications or troubleshooting? Air leak.
We talked about air leaks.
Air leak
It
can be in the system itself. It can be in the tubing, or it can be at the dressing
site. Then we talked about when we might possibly want to clamp it, and the main goal is not to clamp the system, but if you have to, do it for a shortest period of time as possible. Okay. All right.
So we've covered insertion.
Yes.
What to do, how to set it up, your role as the RN. Covered complications.
Yes.
Troubleshooting.
Yes. And now we need to talk about responsibilities of a nurse when we are assisting the physician or the provider in discharging or DCing the
Okay, so if the patient has a pneumothorax, the chest tube's been in a few days, chest x-ray in the morning says, yeah, that lung is fully inflated. The doctor says, hey, I'm going to pull this chest tube today, and he wants you to assist him. What do? Again, you're going to verify the patient, 2 identifiers, proper PPE.
Exactly.
You're going to get the dressing of choice that the provider or physician wants. Most of the time it is an occlusive dressing, a 0-form gauze, big padded gauze on top of that.
Suture
The-
removal kit.
Suture removal kit to get the sutures. But the provider will tell you,
Right.
and if you don't know, ask. Say, what do you want, doc? I'm new to the floor.
Right.
I've never helped take out a chest tube. What dressings do you need? What do you need?
Exactly.
Never be scared to ask your provider or your physician.
You also have to do a timeout with this procedure, the same as you would when they're inserting the procedure. It's still a surgical procedure.
And why would we want to do a timeout if we're putting a chest tube?
Well, if you same thing you just said, you want to check and make sure it's the right position. The right patient.
Right
and
patient.
That you're doing
what if Mr. Jones?
Right, if Mr. Jones is sitting next to Mr. Smith and they both have chest tubes, you want to make sure
obviously don't want to pull out the wrong one.
Exactly.
Right, exactly.
So the main thing is just to make sure that you're doing the right procedure, right patient. So follow those guidelines. So you have everything, every piece of equipment that the provider has asked for. You have all of the specific site dressing that the provider wants to use. So what do you do next, Bodie?
Okay.
What do you
next,
do next?
when the provider's ready, he'll take down the dressing. He'll remove the sutures, and then he'll be ready to go. Sometimes the doctors do it. Most of the time, or sometimes they'll rely on the nurse. Our role here is to instruct the patient and help the patient through the procedure. So what we would do is we would tell the patient to take a deep breath. Deep breath in, hold it, and bear down. Valsalva maneuver. So that is so they're not exhaling or inhaling and changing the pressure in the chest cavity during removal. So you just have them deep breath, hold it, bear down. At that point, the doctor will remove the chest tube. He'll apply his occlusive dressing. He's handling that chest. What you're watching for is signs and symptoms of any respiratory distress, vital signs.
Patient's getting anxious.
Exactly.
You don't want them to start moving around in bed.
Right. So your role in removing it is fairly minimal, but it's important to know what to tell the patient to do, and then you're basically monitoring the patient to make sure that there's no negative sequelae or outcomes from removal of that chest tube.
And a lot of times you'll also be responsible for ordering a post-removal chest X-ray.
Oh, one thing we didn't cover is what to look for in the drainage. Say you get a patient up who's had a chest tube for 3 days, and they've been sleeping all night, and you get them up in the morning to walk them, and of course the good nurse you're going to be, you look at your drainage system and you say, oh, there's 100 cc's in there. Then after you walk them, you notice there's 180, and it's dark, very dark, dark black or dark brown drainage. Is that something to worry about? No. Reasons why is the patient's been sedentary all night, you've gotten them up, you've moved positions, you've got them ambulating, so all that, if it's old dry blood that's in there, you would expect that to come out as a dark brown.
So Bodie, what would you do if you walked the patient, you came back and you noticed you had 180 and it was bright red?
Okay, what does bright red blood indicate?
That means you've got
That's
a new bleed.
a newer bleed. So if you ambulate a patient, or if you're even not ambulating the patient, if you're just monitoring a patient who's laying in bed and you notice a sudden increase in your chest tube drainage, especially if it's bright red. Hey, Mr. Smith, each shift has been having 20 cc's of dark output or clear, serous output. Now all of a sudden, wait a minute, I'm up to 160 and it's bright red. Assess the patient, notify the physician, because that's a change. That could be an active hemothorax or a new bleed inside that chest cavity. So those are good points. So, gone over how to assist, the components, troubleshooting, removal or DC of a chest tube.
Possible complications.
So what do we got left?
Okay, what we have left now is our the questions, the NCLEX questions that we gave you. So everybody has done their pretest, and so you're not graded on the pretest. This is for you just to look and see what you did when you did it. Okay. So the first question, Bodie, you want to go with the first question?
Sure. So the first question that you did on your pretest was the RN caring for a patient with a chest tube notices intermittent bubbling in the water seal chamber of the chest tube drainage system. What is the most appropriate action? The answer is C. Do nothing, as this is a normal finding.
Right. Remember, we talked about that. A little bit of bubbling is okay. Excessive, progressive bubbling means there may be an air leak.
Especially normal if it's intermittent, because with every inspiration and expiration, if air escapes out, which is what we want, where does the air go? It comes through the tubing and boop, pops a little bubble there. So some intermittent bubbling is definitely considered normal in a closed drainage system. Okay? You know what? Okay, alternate.
Okay.
Go ahead.
Number 2, to maximize the chest tube drainage system efficiently, what should happen? A, the chest drainage system should always be below the patient's chest level, and the system should be upright. Like we talked to you when we showed you the system, that there is a bottom piece that enables this system to sit flat on any surface, most especially the floor, or you also have your hangers that go onto the bed. We recommend that you follow what your agency policy or your processes are, but I always suggest that you use the hangers and hang it on the bed. That way when people accidentally bump into it, it doesn't fall over.
Also, make sure your tubing is not coiled, kinked, or anything like that. All right, next one. The RN is caring for a patient with a chest tube. He or she enters the room to find the patient in mild respiratory distress with an oxygen saturation of 89%. What should the RN do first? Answers A, ensure that the chest tube is not clamped, kinked, occluded, or disconnected. First thing you do, check if it's just an occluded tube or a disconnected tube, that's causing the respiratory distress. So if you can fix the problem with the here, it'll fix that. So that's the first thing you should do. Obviously, the next thing is to assess your patient, provide supplemental oxygen. But the first thing is check your chest tube.
Always, yeah. Okay. Number four, insertion of a chest tube is a sterile procedure. However, connecting the drainage tube is not a sterile procedure, and the nurse can wear regular gloves. Okay?
As long as we maintain sterility
of the area,
right.
The insertion area.
Right, next, the RN ambulates a patient with a chest tube. We already answered this one. This was the 100 cc's of dark fluid. That's a normal finding.
Right.
Bright red blood or any increase or any sudden change in the drainage is not.
Okay. Number 6, the function of a chest tube is to remove air and or fluid from the pleural cavity. Okay.
And we talked about that.
And we did talk about that also, that's the function of a chest tube is to remove air, fluid, blood from chest cavity so that we don't have the development of a pneumothorax.
All right, next question. Which one of the following statements by a patient with a chest tube indicates no further education needs or that the patient understands?
Right.
The answer is D, the drainage system must stay below my chest. Because a lot of patients, they are ambulatory. They'll get up and move, and they carry their chest tube with them.
Right.
So they just
or they
need to
sit in a chair
they need to
and
understand
they
that
hold it up against their chest or something.
they just need to understand that it must be
Stay
low. Stay
right.
below the level
to
of
help
the
that that process of fluid coming out. Okay, number 8. Should excessive bubbling be seen in the water cell chamber of the should excessive bubbling be seen in the water cell chamber of the chest drainage system? And we had talked about this also. Bubbling should be seen in the water cell chamber, but if it's excessive bubbling, again, there's probably an air leak.
Right. What are the signs and symptoms of a tension pneumothorax? Select all that apply. Now, we talked about if we clamp, there's a possibility of air getting in the lung, it can't get out, cause a tension pneumo. We didn't quite get into the signs and symptoms. So the answers are hypotension and tracheal deviation to the unaffected side. So what happens is the pressure builds up on the left side.
And moves.
It's pressure. Imagine blowing up a balloon in that side of the chest. You're going to see the mediastinal shift, tracheal deviation to the right, putting pressure on the heart, hence the hypotension, because the cardiac output is decreased. So those are the signs and symptoms. Obviously, the patient will probably have some anxiety, pain, that seems out of proportion to what's
going
just
on.
laying there with the chest tube.
Okay, Mr. Smith has a chest tube. He has become combative and pulls his chest tube out. What is the first nursing action to be taken?
Plug the hole.
Plug the hole. Cover the incision site first with a gloved finger, then with an occlusive dressing. Okay.
All right, so that wraps up the questions. Hopefully
everybody got 90% or better on their test.
So now we're going to take this what we presented here in the video, and hopefully you will all take the 3 minutes of time to watch the anatomy and physiology video that we showed you earlier.
And what with this going on like this, the next step would be when the pre-licensure nursing students come to the class, they've already reviewed this video, they've reviewed the YouTube video, they've reviewed the literature that's in their classroom
material. The corresponding chapter.
Right, they've seen the demonstration on the chest tube drainage system. So when they come to class, what they're going to do is show
a return demonstration
on
how to set up
the setup, and then they'll be given case studies and be put into groups together to discuss it, and then discuss it with the class. We hope you've enjoyed our video on chest tube drainage system.
Thanks for watching.
Bye.